Good morning. Welcome and thank you for joining us for our Northern Light Health Business to Business Zoom conference. We are all aware that the coronavirus has been having a progressively greater impact in Maine, as measured by the number of people testing positive, people being hospitalized, people dying, and by the administrative restrictions placed on us to try and decrease this impact. So what's going on and what can we do? Today, we'll get caught up on the latest COVID-19 information, concentrate some time on vaccines, and talk about ways to support our employees. I'm Dr. Ed Gilkey, Senior Physician Executive at Northern Light Beacon Health. I'll be your moderator for the next hour. Our panelists today are Dr. Jim Jarvis, Director of Clinical Education and Incident Command Section Chief at Northern Light Health. Matt Marston, Associate Vice President at Northern Light Pharmacy. Catherine McLaren, Vice President of Talent and Diversity at Northern Light Health. Before we get started, I'll read our legal disclosure. The coronavirus pandemic is an ongoing, continuously evolving situation. Northern Light Health encourages everyone to follow federal and state governmental guidance and mandates. Northern Light Health does not know the particulars of your situation, so the information presented today is general in nature and is based upon Northern Light Health's own experience, which may or may not apply in your specific situation and which may be revised as we learn more about the coronavirus. Accordingly, following any guidance Northern Light Health presents today in no way guarantees that you, your employees, and/or your customers and clients will not contract or spread the coronavirus. A reminder, this hour is for you. If at any time you have a question for one of our panelists, please use the chat function. I'll keep track of your questions and have our speakers respond. Also, I hope each of you will take a few minutes immediately following our hour to answer our quick 5-question survey. Your input directly impacts our topics and helps guide our future conferences. Let's get started. First, let's get an understanding of your experience with this pandemic. Take a minute and answer our poll question. For your business, how does 2020 compare to other challenging times? Vote away. Three-second warning. Okay, well, I'll end the polling there. So we certainly have a pretty strong pattern of 59% of our participants are showing that 2020 has been the toughest year ever for my business. You know, there's some good buried in it, but mostly really quite challenging. So let's also compare. Let's see if we have those results up there. We'll also compare to Maine Biz. You can see with the polling that was done with the Maine Biz participants, clearly it was a tough year for them. Some actually had it well, and it's probably a business that could be leveraged in the setting of the COVID-19. So we're not too far off with all of that. So thanks for participating there. Next, our panelists will share useful information from their areas of expertise, and then we will have questions and answers. First up is Dr. Jarvis, who will provide the latest information on COVID-19. He'll share with us COVID by the numbers, testing, and some light at the end of the tunnel. Let us see through your binoculars, Dr. Jarvis. You may be on mute.
Actually, I was waiting for the poll to disappear, but I think I have to put it away myself. Well, thank you, Ed. Thank you for the update there. As you can see, we are in the midst of this. This is probably the worst numbers that we've presented since we started doing these webinars way back in the late spring. And so you can see that, in the state of Maine, actually, as of today, we have over 27,000 confirmed cases in Maine, with 372 deaths. So the numbers on the screen there are a little bit behind, just simply because each day we see dramatic increases. Here at Northern Light Health, we are currently taking care of 55 patients inpatient that are positive for COVID-19. Those are numbers that are much larger than we'd seen before. It's actually a little bit of a dip in the last couple of days, but we expect those numbers will continue to rise. The bulk of those are at Eastern Maine Medical Center and down at Mercy Hospital. But what's different now is that we are seeing our smaller hospitals having an increased number of inpatients as well. So this is a real event. This is difficult for us. In addition to our inpatients, we have 61 people who are being cared for at home by our home care and hospice. And more alarming is that our positivity rate, or the percentage of people who get tested who have a positive result, is hovering greater than 7%, and that's an alarming number for the state of Maine. If you remember, when we started these webinars, we were talking about 1-2% at most. Then through the summer and the early part of the fall, we were almost always less than 1% positivity rate. We were just excited about the successes we've had. But now we're seeing the aftermath of our holidays, particularly Thanksgiving holiday. The numbers that you're seeing now really still reflect that holiday weekend for Thanksgiving, and so we expect to see these numbers climb as we get over the holidays at the end of December and beginning of January. We know that a lot of people traveled. We know that a lot of people went and visited other individuals, and that will just result in us seeing increased numbers as we go along. Next slide, please. So testing continues to be, the mainstay for us to follow what we do for COVID-19. And I will say that we are probably in a much better spot now for testing than we have been. Most of the time I'd spend talking about testing, saying, that we're very limited in our testing supplies, which is hampering our ability to get tests when we need them clinically. I'm delighted to say that with a partnership with the state of Maine, we have been able to get more of the rapid tests that have some utility for us in clinical situations, for when people are symptomatic, and being able to test them more rapidly. What that does is that also offloads our need to be able to use our PCR testing, which is the gold standard testing and the test that we recommend most for people who are asymptomatic, that we were able to offload some of that to these rapid tests and therefore have more capabilities. There is still a delay, particularly when we're not doing testing for clinical reasons. So for somebody who has had travel, or had a very mild exposure or something like that, there is still delay. So please be aware that if you do get tested and it's not for a clinical reason, it may take 5 or more days to get those results back. And that's just a matter of supply and demand right now. And demand is very, very high, and so that puts us behind in a lot of that. But we are doing better in testing than we had been, and despite the fact that we're seeing the numbers rise. Next slide. So let's talk some more positive things. We're starting to see some light now in the darkness of this pandemic. And so I really want to kind of go over some of the things that we have here in the state of Maine and go over some of our vaccine numbers, because we do have the availability to vaccinate now. The state of Maine has vaccinated over 28,000 individuals. That is obviously way short of the 1.4 million people that live in our state. The good news is, though, that Maine leads the country in actually getting vaccine into people's arms. As of this morning, we have administered 54% of the vaccine that has been delivered to the state of Maine. That's remarkable when you look at other states that are way lower than that. I have been asked repeatedly why we are not following the Florida model, where they posted a phone number up and said whoever wants to get vaccinated can just call this number and get set up. To date, Florida has used less than 30% of its vaccine. So while it looks like they may be ahead of us because they're offering vaccine outside of healthcare workers, currently that model is not working for them. They are not getting vaccine into arms, which is the most important thing we can do right now. And that leads us into what's our plan for the future. So right now, it is critically important that we continue to vaccinate our healthcare workers. And when we use the term healthcare workers, I know a lot of people just think of doctors and nurses, but there are so many other people that are involved in carrying out our healthcare. We need the people who clean up our rooms. We need the people who provide food services to be vaccinated, because doctors and nurses can't do their jobs without them. We need our phlebotomists to be able to draw blood. We need our lab personnel to be able to run those tests. We need our front office staff to be able to get patients in and out in a scheduled fashion. I can assure you as a doctor, you do not want me on the phone when you call to make an appointment. It will take 30, 40, 50 minutes or more for me to get through our computer system. I need my front desk person vaccinated so they stay safe, because they're my front line. They're the person that unfortunately continues to argue with individuals who do not want to wear masks in our facilities. And so when we say healthcare workers, that is a very broad term. And so when you hear reports in the media that we are not vaccinating doctors because we're vaccinating other individuals, that's absolutely unfounded and actually makes no good business sense. So that's where we are right now, is trying to get our healthcare workers vaccinated, as well as those individuals who live in our long-term care facilities, where we know that they are critically susceptible to this virus, and then having long-term consequences from it. And so that's where our strategy is right now. But right now, as we talk and as we are getting those frontline people vaccinated, we are planning for the next wave, which will be to vaccinate more individuals who are at high risk, and those people who work in essential industries that we need to be able to keep functioning as a society. And then the greater plan for how do we vaccinate everyone in the state of Maine. All of those plans are undertaken right now. I will tell you that as you look around the country and see the chaos they are having, look at the state of Maine. We are not seeing that chaos, and that's because we are pre-planning. We are making sure that what we do makes sense, that we have the vaccine in place to be able to vaccinate people, and that we have the resources to do so. So that's where we are right now. So that asks the next question, where are these vaccines and how do I get mine? Well, that's the problem. Is right now, I told you that Maine has vaccinated 28,000 people, and that represents more than half of the vaccine that's been given to us. So if you do the math, that's only about 60,000 doses. That's less than 60,000 doses of vaccine that's been given to the state of Maine. Some of that, the reason why there's a delay in its usage, is because of those long-term care facilities. It takes time to strategically get to those long-term care facilities and vaccinate those individuals. The vaccine that's been delivered to our hospitals is in people's arms as we speak. And so that's good news, but that's woefully under the amount of vaccine that we need. And so until we start seeing that we have vaccine supplies to be able to vaccinate between 10 and 50,000 people a day in the state of Maine, it will be a very slow process for us getting that vaccine out. I want you to all understand that you, your employees, your customers, your family, your friends, you are all being considered as we come through this plan. This plan will be the best plan that there is out there, and I don't say that to be in any way trying to be grandiose. It's because this is what Maine does well. We have done very well through this entire pandemic of reaching a consensus of how best to manage this disease, how best to manage this pandemic, and how best to take care of you. Now, with that, I'm going to transition over to our friend Matt, who's going to tell you a little bit more specifics about this vaccine and what it is that you need to know as you prepare for when we can vaccinate the general population.
Well, thanks, Jim. And next up, in fact, is Matt Marston. Along with Dr. Jarvis and others, Matt, you have been immersed in rolling out vaccinations across Maine. Help us to understand what's happening.
Great. Thank you, Dr. Gilkey, and thank you, Dr. Jarvis, for providing the update and the hope that this vaccine represents. I'm honored to be able to stand by my colleagues while they start to receive this vaccine in the initial stages for healthcare workers, and see the hope that this brings and the pathway for us to get out of this pandemic is starting to become more clear. So what I really want to share with all of you that may not be immersed in healthcare is a little bit of details about the vaccine itself to build understanding and awareness, and also share what this could mean for employers. So COVID-19 vaccines, several are in development beyond the two that have initially received emergency use authorization, the Pfizer and Moderna products that you might be hearing about on the news. And what I want to stress is that these medications, the Pfizer and Moderna vaccines included, all go through the same rigorous clinical trial testing as any other medication that hits the market. And what this represents in a trial is moving from small groups of people, or phase 1, to larger groups of people, phase 2, and then phase 3, which are still ongoing as well, which represent tens of thousands of individuals, which is more than 70,000 volunteers for both the Pfizer and the Moderna studies, in which they get safety and effectiveness data before they make the determination that it's safe to release into market. And you hear about Operation Warp Speed, and what I have to say is the Warp Speed component of it is eliminating some of the wait times and administrative paperwork behind the process with the FDA to expedite that review of clinical trial data, not expediting the actual clinical trials and research that go behind the vaccines. So as mentioned, there's 2 vaccines currently that have been approved through emergency use authorization. And what emergency use authorization means is, again, an expedited approval process that pushes these medications or vaccines ahead of the pack in review due to the nature of the pandemic and the state of emergency that we are under. So it's a lever that the FDA has to pull to put those reviews ahead of other medications that are in the pipeline. So both vaccines were tested in tens of thousands of adults from diverse backgrounds. And the clinical trial data show that both vaccines are both safe and effective in preventing COVID-19. And I'll show the data behind that. And currently, one big unknown is how long this protection from the vaccines may last. These clinical trials are still ongoing, and they've been several months. To get long-term data on how long this immunity will last, we really need several years to monitor the results of those trials to get that information. A little bit about how these vaccines work. There's a lot out there in the media, both true and false, about how these mRNA vaccines work. Now, mRNA, or messenger RNA, is what our body naturally produces to send messages to cells on proteins to produce any sort of natural bodily function. And the virus, the coronavirus, actually has mRNA as well. And the gene sequencing of the virus itself was decoded early in the pandemic to be able to identify different components of the virus and how those are coded for in their genome. So what researchers did was they found a likely target for the vaccine, which is the coronavirus spikes on the outer surface of the the virus. And what they did was they discovered how to replicate those spikes through finding the code or the messenger RNA that codes for the production of that. They then take that messenger RNA and they encoded it in what's called a lipid nanoparticle, which is a fancy way of saying a layer of fat. I think we all know with our New Year's resolutions that our body does not break down fat very readily. So this provides a nice protective coating for that messenger RNA that ordinarily is destroyed quite rapidly by the body to be able to get to its target. So the next step in this process is to actually administer the vaccine. So here you can see a healthcare worker administering that vaccine to a patient. And the next step from there is when the vaccine actually starts taking effect in the body. So here is a cell, a normal body cell, that the lipid nanoparticle can be passed through that cell membrane into the cell itself. And just like your body naturally translates RNA, the vaccine RNA gets translated to make spike proteins, the same ones that exist on the surface of a virus, that can then be recognized by your immune system. So your immune system kicks in, recognizes those spikes, attacks the spikes, and then you develop memory or immunity to that virus or those spikes that are on the surface of the virus. And then that RNA is rapidly degraded and destroyed. So I want to stress here that there is actually no virus in this vaccine. All the vaccine is a delivery mechanism for this message to tell your body to produce the spikes that induce the immune response. So there is absolutely no way to get COVID-19 from this vaccine. It also has no interaction with DNA, which is one of those other false messages that you see out there. So is the vaccine itself effective? And here we have the trial results from the Pfizer vaccine. The blue line is actually placebo, or an inert substance, usually just regular salt and water, that's injected into the body to provide a control group for the study. The bottom line is the vaccine group. And what this represents is rates of coronavirus infection among the two groups. So you can see the placebo group saw a significant increase in the number of COVID infections as compared to those that received the vaccine, which translates with both doses a 95% efficacy or effectiveness of that vaccine. And so next we have the Moderna vaccine. And you can see that the effectiveness of that vaccine is 94.1%, almost identical in terms of clinical effect. The difference of 0.9% between two studies can't really be compared to say one's better than the other. Both are highly effective vaccines. Here we have listed some common side effects that have been seen from the messenger RNA COVID-19 vaccines, as well as common effects of COVID-19 disease. So you can see that some of these effects actually overlap a little bit in terms of how they present, but the mRNA COVID-19 vaccines, these side effects are a direct result of the immune response that's induced from receiving the vaccine. When you receive the vaccine and you develop an immune response, you get all the same things to a mild degree that you might get with an infection. So headache, fatigue, some injection site pain, even low degree of fever and chills, which are less common. But this just represents your body mounting that immune response. There's also some rare side effects, which again are rare. There's allergic reactions, which we have strategies to manage on site, just like with any vaccine that's out there. There's been some reports of swollen lymph nodes and Bell's palsy. I'll say in the 7,700 doses that we've administered so far, I haven't seen any of those. So again, very similar effect profile that you would see to any other vaccine that's on the market. So what to expect in the process of getting vaccinated? So this is a 2-dose vaccine series. After receiving dose 1, it's expected that those side effects that we talked about of that mounting of the immune response can be seen in days 1 through 7 after receiving the vaccine. In most patients, it resolves after day 1 after receiving the vaccine. After dose 2, the side effects can again be seen, and actually a little bit more common to see those after the second dose because your body mounts a faster immune response, which again resolve most typically a day after receiving that dose. And then it's expected that 7 days after receiving the second dose that you achieve that 95% immunity. However, it's important to mention that you have to continue to follow all the public health guidances because it's still unknown at this time if those that are vaccinated can actually carry the virus and still pass it on to somebody else. What is known is you have a 95% chance of not developing symptoms to that coronavirus. So it's anticipated and expected that it will protect against transmission, but we still have ongoing studies to evaluate for sure if that's the case. So current guidance is to mask and provide social distancing. Here is a direct comparison between symptoms of COVID-19 and the messenger RNA vaccine. In these red categories, cough, sore throat, shortness of breath, loss of taste or smell, and loss of appetite are important because these are not known side effects of the vaccine. So as was mentioned, it can take up to 7 days after dose 2 to get immunity to COVID-19. So if you receive, for example, dose 1 of the vaccine and develop any of these symptoms in the red category, getting tested for COVID-19 is still important because it is possible to get sick with COVID-19 while waiting for that immunity to occur. So what to expect as an employer and when? The number one question that we receive from everyone is, when can I get my vaccine? So this main CDC has multiple phases of this rollout, which are listed here and can be found on the CDC website. We currently are in the very first phase, which is healthcare workers and residents of long-term care facilities. We're actively working with the main CDC to complete all these steps of phase 1A, which includes not just hospital healthcare workers, but those that are out in private practices as well. And we're working on plans and communication strategies with the state to vaccinate those groups as soon as we possibly can. And then we're actively planning for rollout of phase 1B, which currently, and this is fluid as well depending on availability of vaccine, is slated for people over the age of 75 and frontline essential workers, which is still being defined. Some unique characteristics of this vaccine from a distribution standpoint are as follows. It has complex cold storage requirements, which makes this vaccine more difficult to manage in terms of rolling out and making available in remote locations. We, for example, have a minus 80-degree freezer here in Bangor that stores the Pfizer vaccine. And if you pull it out of that freezer, it's only good for 5 days under regular refrigeration. They're both also multi-dose vials. And when you puncture the vial, all doses in that vial have to be administered within a 6-hour time period, which poses other challenges. So our approach to public vaccination is to first vaccinate healthcare facilities en masse, and then move to referral-based public clinics. And the reason for these referral-based clinics is because we need to substratify based off of risk, as was identified with the CDC guidance. Then when the vaccine is more publicly available, moving into more of a mass vaccination type model, where we administer, the 10 to 50,000 doses in a day that Dr. Jarvis was mentioning across the state. And then we will also hopefully move into employer-sponsored vaccination clinics if we find that more than 2 doses a year are required to maintain that immunity, which is still an unknown at this point. And there's other vaccines in development that have single dose vaccination characteristics with better cold stability that may make that feasible at that point. So another question that I get from a lot of employers is, should the vaccine be mandatory? And I'm a pharmacist, I'm not a lawyer, so take this advice as you will, but there's several pros and cons to be considered before implementing some type of mandatory vaccination requirement. Some of the pros to this approach are it helps to ensure the safety of your employees and customers. It reduces time out of work and lowers overall healthcare expenses, and we've seen this with other vaccines. Maine is also an at-will employment state, which allows for employers to make vaccination a condition of employment. So some cons with this approach: COVID-19 vaccines do not currently have full FDA approval, as phase 3 clinical trials are still ongoing. So more information is still yet to come about these vaccines. Also, valid medical exemptions do still exist for vaccination. That's why it's so important for large numbers of people to get vaccinated, is to protect, in particular, those that are unable to receive the vaccine through herd immunity. Employees may also hold strong religious or philosophical beliefs surrounding vaccination, which could affect the ability to retain those employees as a potential piece. So that needs to be weighed as a con against the benefits of mandatory vaccination. So we have posted for your reading pleasure some links to some really great resources to get some additional detailed information about coronavirus vaccines. So with that, I'll pass that on, and I'm happy to answer any questions afterwards.
Well, thanks, Matt. And thanks to you and Dr. Jarvis and the whole team of people that are working across the state to make this all happen. It really is quite impressive. So before we get to Catherine, let's take a minute for another poll question. And that question is, when was the last time you were physically at your place of work? Vote away. Three-second warning. Great. Well, it looks like a lot of people have been there this week, and folks have not stopped being there regularly. So completely involved in this. It seems like a handful of people, probably ranging from 10 to 20%, are staying out of the work environment. Let's compare now to take a look at the main biz numbers. And you can see there that I Never Stop Being There regularly had the highest votes this week as well. And then there were actually a significant number, probably a bit more than our panel here, where they stayed at home completely. So it gives you a read on where you are relative to everyone else. Okay. Well, Catherine, all the science and all the operations are really about the people. The people in our workforce are living this every day. Some have been working remotely. Please share some ways that owners and managers can support their people. Catherine?
Sure, yeah, thanks. And you know, what's interesting about the poll that you guys just completed is that it looks like not one person who participated was working remotely before the pandemic. And of course, what we know is that for many employers, and certainly Northern Light Health included, not all work can be done remotely. There are certainly things that need to be done on site. But this exodus that we saw from the workplace essentially since March was really around allowing for social distancing, as we know, for safety reasons. And I think, and I know this is the case for us, that what we've discovered, however, is that there were some real advantages, and there continue to be for employees and for employers. And so one of the things I know is coming up for many employers as we start to see this sort of light and move towards not being in crisis as consistently as we have been, is what do we do now? And so what I wanted to share with you is a little bit of information about what the data tell us related to remote work. And I think that this experience has really sort of accelerated many employers' experiences with it. And some employers I know who really weren't considering it so much before have found some advantages. And in addition to the cost savings, which you can see here potentially, both for the employee and for the employer, there's also a real improvement in retention in many cases. And as we know, we have sometimes a challenging labor market, especially here in Maine, in terms of finding people who are actively looking for work. And in addition, employees are absent much less. Now, I have certainly heard the response to that I've heard from people is, well, of course they are. If they're working remotely, it's probably from home, so they're not going to call out. They're just going to not work from home. However, we also know that quality and productivity are greatly improved. So that argument or that concern generally just does not play out in the evidence. What I want to talk about a little bit and is as employers are thinking about, okay, we may have sent a portion or our entire workforce home, and now what are we going to do? How do we start to sort of formalize what's been going on? A similar experience. It's sort of been like, look, we're just going to figure this out as we go, and we have all kinds of things going on related to cats and dogs and children, and not great connectivity and all kinds of issues. And we've just kind of rolled with it because that's what made sense and that's what we needed to do. As we move towards having a more sort of formal approach to remote work, we'll likely be in a situation, most of us as employers, if we have the ability for people to work from home, for the three scenarios. One is full remote, the second is a hybrid model, and the third is entirely at work. And I can tell you on my team right now, I have all three of those. The first thing that becomes really important is to have a very specific policy that answers a lot of questions up front, because what I have found in talking with employees and also talking with employers is that the confusion around who's responsible for what and how it's going to work is often the thing that becomes challenging, because there are assumptions. So a very clear general policy around who's responsible for what, the equipment, the work time requirements for the remote workspace, when might an employee need to be on site, and safety concerns around ergonomics and other issues. because we have workers' compensation and other things to consider, set the tone, and then a specific agreement for the employee in terms of what will your particular situation look like. And there are lots of great templates for that. I've been looking at a lot of them recently. And that's essentially a signed document that says, here's how it's going to work for you. And that includes the schedule and expectations around productivity standards, how metrics, how will we know that the work is getting done, back to the internet connectivity requirements, the fact that it probably needs to be a quiet space that's dedicated to doing the work, etc. And also, what can I work anywhere remotely, or are there certain locations that are available to me? And then within that is the actual practice. And I'm sure that many of you have experience with this. I've been talking to a lot of people, but using video communication whenever possible. We have this sort of complicated situation now because there's a lot of concern that people working remotely are feeling isolated, but we are currently in a situation where people are isolated. So it's very difficult to know what's part of that versus this overlay, of course, of the reason that we sent a lot of people home to begin with. Being deliberate about checking in with people. I have seen leaders do some really interesting things, just having a drop-in video space, a virtual space for people to come hang out if they want to and do their work, but kind of chat at the same time to simulate an in-office experience. Creating forums for teams and coworkers to work. So establishing, if you have an instant message system or some way that people generally communicate that way. Etiquette, because we can't take the social cues that we would take in person. If I see that someone appears to be heavily involved in work, I'm probably not going to interrupt them. But when I can't see them and I see that they are technically available, if we have an IM function that we use, I may just barge right into the middle of something they're doing. So setting up some etiquette around how we communicate and what the response time expectations are. And then addressing and resolving any concerns really quickly becomes super important. And we've seen this play out in the last 10 or 11 months. If there is an issue, we're just going to take care of it right away. And most of the time it can be resolved. And then being very consistent with your employees. And if you are a leader over a team, making sure that you're as consistent as possible with all of the people on your team. In terms of keeping remote workers engaged, and this question comes up quite a bit from our leaders, how do I do that? I don't want to sound flip when I say this, but it's not entirely different than how you would do it if you were physically in a similar space, except that you don't have that time that you just sort of run into each other accidentally or just because you happen to both physically be in the same space. People do want to work on a team and they want to feel like they're part of something. So of course, creating those forums is really important. Connecting the work to the bigger picture. Just because someone isn't at work, of course, doesn't mean that their desire for growth and development disappears. And so making sure that you are attending to that part. And I know that's been challenging in the last 10 months because there have been so many other things that likely needed to take priority over that. So as we start to think about transitioning to what our new normal will be, that's something that we're spending a lot of time thinking about. And then certainly knowing your employees, as we know, some people desire more connection and attention, and others are more able to work autonomously, and understanding how that works for each of your folks makes a big difference. But again, I would go back to starting with the expectations up front about how this will work and who's responsible for what, and then take it from there.
Well, thanks, Catherine. Now let's focus on your questions. I will group similar questions together so we can address as many questions as possible. The first question is for Matt. How many people need to be vaccinated in Maine for the virus to decrease or even disappear?
So exact numbers about the coronavirus are few and far between, as we haven't been through a pandemic such as this before with the coronavirus. However, in inferring from other viruses that we currently have vaccinations for, you typically see a 60% threshold target for when things start to diminish and get better in terms of population covered by a vaccine. And to eradicate a virus requires much higher and sustained immunity in order to accomplish that. So receiving well north of 80% of our population vaccinated will really be necessary to have our levels of COVID-19 infection plummet to the levels that we're all hoping for. So getting everyone out there and getting vaccinated is going to be critically important.
So we have months ahead of us.
We do.
Okay. The next question is for Catherine. In spite of the data you shared, I'm concerned about productivity of employees working remotely. How do I find the management balance between supporting my employees to work remotely and productivity? So a little bit more on that.
Yeah, it's a question that comes up a lot, and my response to that is, if you don't have reports that you run for remote working employees that can show you that, then the next best thing is to ask yourself, how did I know they were productive when they were in the office, right? And I will tell you, my sense is that sometimes leaders or employers base what they assume the productivity will be on how productive they think they are remotely. And so that's something to consider. By and large, employees want to be successful. And what we have found is that the employees who were not all that productive at work are not as productive at home. And the ones who were, the solid employees, which is the majority, continue to be, if not more so, at home.
Mm-hmm. Well, thank you. Dr. Jarvis, the next question is for you. What's the concern about new strains of this virus around the world and in the U.S.? And then a follow-up question is, does it mean anything regarding vaccine effectiveness?
It's a great question, Ed, because we see a lot of this in the media right now. So the two strains I believe you're talking about is one from the United Kingdom and one from South Africa. And what we found is that these strains seem to be more infectious, but not necessarily more virulent. And those sound like semantics, but in the world of medicine, they actually have true meaning. So infectious means the ability to spread from one individual to another. Virility means the ability of it to cause disease. And so what we mean by this is that these two new strains appear to spread between people much more readily than the strain that we were dealing with for most of the year, but they do not cause any more disease than the original strain. But the problem is, of course, if it infects more people, we're going to have more people with disease. It's just about math in that regard. So that's the big concern for us. We don't want something that spreads 2 or 3 times faster than the other one, because it will just mean more people get sick and we'll have more problems from that. As far as vaccine goes, the way these vaccines were created, they target a particular protein, as Matt said, around the coat of the virus. And we do not feel that there is such a difference between these 3 strains that it would affect the vaccine's effectiveness. Time will tell, but when we look at what these viruses look like in real life, it appears they're similar enough that the vaccine should be effective for all of them. And in fact, we'll know that relatively soon, particularly in the UK, where that one strain is now the predominant strain, and people are being vaccinated on a regular basis in the United Kingdom. So thank you for that, Ed.
Great, thanks. Jim, just a quick follow-up on that. So I've been reading that the new strains are maybe 70–75% more infectious. So that comes out to a little under twice as effective as the initial strain. Is that correct? Am I interpreting that the right way?
Yeah, I think so. Again, it's still early for us to tell. Sometimes the media, here's a couple of numbers, does some quick math, and puts, they like to use percentiles. So I think it's still more to come on all of that, but it is concerning for us, and we do know that at least the UK strain is here in the United States. I was asked yesterday if it's here in Maine. While we don't have any laboratory confirmation of that, just assume that it's here. In fact, assume that everybody you come in contact with has been infected with COVID-19. That's why we keep telling you, wear your face mask, stay 6 feet apart, don't congregate outside your own household, and wash your hands frequently. If you do that, if you make that assumption, you will stay far safer than if you do not.
Mm-hmm. Yeah, well stated. Matt, I have a series of questions about the vaccine, so I'm gonna bombard you with a couple in a row here, if I may.
All
Um,
right.
the first one is, what, if anything, should people with certain food allergies or medical allergies be aware of when getting a vaccine?
Okay, that's a good question. So for food allergies, there's really two components of the vaccine that can be found in food products. And one is sucrose, which there isn't a high degree of allergies to that out in the population. And the other is PEG, or polyethylene glycol. And that is most typically actually seen in over-the-counter medications. It's actually a product that's used as an inert ingredient in those medications. One more common one's Miralax that you might think of, which is polyethylene glycol by itself as a laxative. So it is out there in other products. However, these are not anything that trigger a very large degree of allergic reactions in the general public. So in terms of food allergies, there's nothing of particular concern. Latex is not present in these products, as well as some of the other common items in medications that people might become allergic to. Now, for people that have a history of allergic reactions, however, there is advisement for all patients to wait 15 minutes after receiving the vaccine, just in case you have an allergic reaction, because it is one of those rare side effects of the vaccine. So everyone should plan on waiting on site for 15 minutes after receiving a dose of the vaccine, just in case you have an allergic reaction. So trained medical personnel can respond to that, which is rapidly reversible. And for those that have a history of allergic reactions, including anaphylaxis, which is the most common, where difficulty breathing occurs, you might think of needing an EpiPen, then that requires a 30-minute observation period. And if anyone has a history of allergic reaction to this vaccine itself, let's say you get dose 1 and you have an allergic reaction, you should not receive dose 2. So that's the only true contraindication, meaning that you should not receive the vaccine at all, is if you've had a prior allergic reaction to the vaccine itself.
So just a quick follow-up question on that. So for people getting the anaphylactic type of reaction, so that's the dramatic one where people can actually die from it. How many of those that you're aware of have occurred across the country at this point?
I'm not sure the exact figure across the country. However, there definitely have been incidents. I think there was one in the media just recently in Portland, in our own state, of a healthcare worker that had an anaphylactic reaction to the vaccine. It is very possible. It's also very possible with flu vaccine or most of the other vaccines that you see out there on the market. So this advisement, I think, is very relevant for vaccines in general, not just the coronavirus vaccine.
Yeah. So this is actually a pretty rare event, though, right? I mean, we're measuring people in, some number around 10 or something like that, right?
Yeah.
You're not, it's not a whole lot. It's not a common occurrence whatsoever, and it's not unlike every other vaccine that we give. Correct?
Correct. So far,
Yeah,
there's no sign that it's significantly higher rate.
Okay. Yeah. So I think when people are trying to decide for themselves about the vaccination, to understand this is no different than other vaccinations. There's not an increase in this anaphylaxis. That's the way to deal with it is to know if you've had anaphylaxis in the past related to it, and stick around for that 15, 20 minutes if you have some kind of history, a half an hour, and stay in that healthcare environment. So we can manage that. Okay, I still have a couple more for you, Matt.
All right.
This one, I don't think you're going to have an answer for, but I'm going to ask anyway. Is there an age cutoff date? For example, if someone turns 65 on March 1st, but the vaccine has already been given to 65-year-olds, can they receive it right after March 1st? So, that's probably going to be your best guess, I think, huh?
Yeah, so the way in which the age limit will be tracked and enforced is still very much in the planning stages with the state. So we don't have a firm answer for that. I know that they're using that as their window in some of the initial phases that they're discussing on rollout of the vaccine, but that's still very fluid at this time.
Mm-hmm. Yeah, and just kind of paying attention to what the philosophy is across our state. We're really trying to get to everyone, and we will have ways to backfill. So,
Correct.
yeah.
And the number one driver of that is vaccine supply. So as Dr. Jarvis mentioned, when we get the vaccine, we are administering it. So our mantra is, as soon as that vaccine comes in, we're finding ways to get it into arms.
Perfect.
So, and the state has the same mantra, but the state is receiving allocations from the federal government through Operation Warp Speed. So as that vaccine is coming in, that's when the levers are being lifted and we're moving into other groups. So that's why there's a lot of uncertainty as to the when we can move into these other groups, is because it's very supply dependent.
Mm-hmm. Okay, thanks. The next question is for Catherine. How do you train leaders on the importance of engagement during work from home? We have done info sessions, provided support materials, and we're still finding some employees to be disengaged.
Well, we do similar things. I mean, there are all kinds of ways to train leaders, but the direct relationship with the leader is certainly one of the most important pieces related to engagement. But there are a lot of other factors going on that might be contributing to an employee feeling disengaged. And one of the things I would point out is that remote work is not for everyone. Some people, it just really doesn't work for them. What we're trying to do is create a culture where people can set up something that really works well for them. But in terms of training leaders, I think certainly giving them practical skills, making sure that they understand why it's important, what the consequences are of that not being the case. The other thing I would say is that right now, it feels like we've all been so focused on this for so long, because that's true, that there are a lot of other things that have sort of gotten put on the back burner and haven't gotten as much attention. And I think it's very easy to say, well, I'll deal with that when things calm down. But if that is at the cost of engagement with employees and with teams, then that's something else that you may want to address with your leaders around, look, we can't get through this and then find that we have a workforce that isn't being productive and isn't engaged and is going to leave. So it's a great question, and we could spend a lot of time on it, but essentially I think it's digging down into why might that employee be disengaged, and maybe asking the employee some questions about what might help.
Thanks, Catherine. I have another sort of unrelated question for you, Catherine. Does an employer have the right to require employees to work at the office if they are scared of getting COVID at work? And we'll qualify by saying you're not an attorney.
That's right. Yes, and deliberately so. Nothing against attorneys, but I don't know. I don't think I'd be very good at it. Yeah, I mean, officially, my understanding is if the requirement is that the position is at work, then it is at work, unless there is this is where I'm not an attorney, a legal reason as to why that person can't be there. But anxiety about being in the office or at the workplace, I should say, is not a reason in and of itself to move work remotely, especially if that just doesn't seem feasible.
Yeah, I'll add my 2 cents. We're working with the workforce as well and making those decisions. And I think it's really important to connect effectively to the primary care provider for your employee to really weigh in on whether they think it's safe. So there might be information I don't know as an employer, such as somebody's immunocompromised, they're really at much higher risk than what I'm thinking they are. I think that's where partnership on behalf of the employee with the PCP would make a lot of sense. So let's see, we got a bunch of other questions here. Let me just get to this here. I wanted to ask this one of Dr. Jarvis. From a restaurant owner perspective, as the answers affect the budget, what are the likely requirements for next summer, such as for masks, social distancing of tables, contact tracing. So once again, we're asking you to look into your crystal ball, which I know is foggy to start with. So let's make our best guess at this, Jim.
Yeah, I appreciate that. I wish I was so good at predicting everything, because then I would play the stock market, but I don't do that. So my prediction right now is that plan as if you are going to continue the way we are doing things right now. Even if we were to get massive amounts of vaccine, if you do the math for the state of Maine, we are talking about, needing to vaccinate, like I said, between 10 and 50,000 individuals a day in order to get them their first and second dose by the end of summer. That's a huge ask. That's a huge lift. That's something that none of us have ever seen a request like that in our lifetimes. So with that said, the virus will still be here. And even with vaccination, we know the virus will still be here. That's just a matter of fact. That's the way viruses work. And so there will always be those who have not been vaccinated, some because of choice and some because they have a condition that does not allow them to be vaccinated. So that lends the virus the ability to continue to spread. So yes, we will still be wearing masks. We will still be requiring people to wash their hands on a regular basis, and probably still be looking at the requirements for social distancing. What we need to get to first is to have enough of this virus around us under control, so that there's less virus in our communities, so at least we can get back to opening up and doing things in a more normal fashion. But normal for a while is going to include wearing face coverings and trying to keep people 6 feet apart.
Great, thanks, Jim. Matt, I got a couple more questions for you on vaccines, and I'll point out that our time is running short, so we'll have to keep our answers focused here. I really want to get to this. I'm going to read you one question and then follow it up and then try to answer. What will be the vehicle for people to sign up for the vaccine? A web portal like other states? And then here's another question. When do you think the general public will be offered vaccinations, and how will they be offered? So similar questions there.
Okay, so taking the first question, how will people sign up to get the vaccine? This currently would be very dependent on the institution in which you'd be receiving the vaccine at. I know for us, we've developed a online scheduling program that also has assessment questions that can be completed to enroll for vaccination. So we're working on making that available externally for when we move into those phases. So that's a work effort that's currently underway. Some groups might have a phoned-in appointment model. So it's going to depend on where you are instructed to go to receive the vaccine primarily, and then following up with those groups to figure out what their method is to provide vaccine. I will say we're not there yet. So as soon as the vaccine is available where we can extend it externally, we will be reaching out to those groups and providing instructions on how to sign up and get access to that vaccine.
Yeah,
okay.
Ed, if you give me a chance just to piggyback quickly,
Yeah,
the issue here is that, the public health structure in the state of Maine is not where it should be, and certainly not anything that can handle this pandemic. So the state is really relying on public-private partnerships, such as with Northern Light Health, and that's what makes it seem like it's a little bit fragmented. We are not the state. We are a private company. And the way our business runs is different than the way the state business runs, but we are working together, and that's the reason why it seems piecemeal. But in the background, we are actually united in how we're doing things.
Yeah,
Great.
And so the second question was, when do we expect it to be available to the general public? Mm-hmm. So general public meaning wide open accessibility. The most recent time frame that I've seen from the federal CDC, which would also apply to us here in the state of Maine, because remember, it's heavily dependent on supply of the vaccine, is summer. So very loose time frame, and it just goes to show that there's a lot of variables in terms of when things are going to loosen up, to what groups, to what extent. So a lot of unknowns at this point.
Yeah, I mean, we can certainly play with the math and start guessing. Let's say we do get to 10,000 doses per day out there, and let's assume that we could do that 5 days a week. People could start using that math and start guessing when we're going to get to that, 70, 80% penetration into our close to 1.4 million people. So those are the kind of numbers we play with to try to figure it out. I have one last one here for you, Matt. When do you think sanitation workers will be offered the vaccination?
Yeah, so that also will fall back to the state in terms of how they intend to roll out and allocate that vaccine. So at this time, that's not an answer that I know. Back on the previous slides with the state CDC, the idea of essential workers, that still needs a lot more definition and a lot more color filled in as these plans unfold and develop in the weeks, months ahead.
Great. Okay, well, thank you. I'm going to try to answer one more question that's out there from a participant. How will healthcare workers in small independent not-for-profits be contacted with the vaccine, and some specifics about who they're working with? That's actually part of the plan that Dr. Jarvis was talking about. The details behind it will be released over the coming weeks to say how we're going to connect with everybody. The good thing is everybody is being considered, so I'm just reinforcing what Dr. Jarvis had said. So with that, we're at the top of the hour. We've included some additional resources for you at the end of the slides today. Thank you all for joining us, and thank you to our speakers. I hope this hour has been a help to support you, your employees, and our communities to safely manage your business. Just a reminder, we will be emailing you a survey right after our conference. Please be sure to give us your feedback so we can continue to provide relevant information. Our next session will be on January 21st, and we'll focus on employee mental health and feelings of loneliness, increased substance use and abuse, and the latest on COVID-19. We will send you the link for this session. We encourage you to share the invitation with your friends, colleagues, and others who might benefit from this information. By working together, we will keep Maine safe. Thank you and have a good afternoon.